we need to stop calling it servant leadership. It is the only type of leadership. I still use the term servant leadership, and I hope that is my overarching philosophy of leadership. And I agree with Patrick Lencioni. It is the only kind of leadership. It shouldn't be a component of leadership. But I believe a leadership philosophy that is really emphasizing serving others, trusting and empowering others. I believe that is what I try to live by. I believe that is servant leadership. I also believe that is the right leadership, the best leadership. And so I do try to live by that uh, as best I can.
Welcome to the Health Leader Forge. My name is Mark Bonica, and I'm an associate professor in the Department of Health Management and Policy at the University of New Hampshire. Today's guest is Chris Dougherty, the president and CEO of Brattleboro Memorial Hospital in Brattleboro, Vermont. Chris knew from a young age that he wanted to be a healthcare leader to serve the most vulnerable in our communities. And he has done exactly that, having been a hospital CEO on both coasts and in Texas. In this podcast, Chris shares his career journey and the lessons he learned from working in different types of hospitals and in different geographies, leading up to his current role as CEO of a community hospital here in northern New England. I hope you enjoy this podcast, and if you do, won't you give it a rating on Apple, Spotify, or wherever you may be listening, or better yet, share it with a friend. Thanks for listening. And here is Chris Dougherty. Welcome to the podcast, Chris.
Well, thank you, Mark. It is always great to talk to you. I look forward to talking to you today.
Great. So looking at your background, you did your bachelor's in politics at Allentown College of St. Francis de Sales in Center Valley, Pennsylvania. What brought you to Allentown, and why did you study politics?
Great questions. Well, Allentown was about an hour and a half from where I grew up in Wilmington, Delaware. It was actually a Catholic college, hence the St. Francis de Sales connection, which was important to me from a values perspective. I did not go to Catholic school at all through high school, middle school, et cetera. I was in public schools, but I thought as I was getting into college, I'd like to be exposed to a Catholic education. It's a liberal arts education as well. And when I got there, I started out as a business administration major. I knew I wanted to get into healthcare administration in some fashion. Wasn't sure where. I was thinking long-term care at that point in time. And my advisor actually talked to me about maybe it would be better to get into politics as a major for two big reasons. Reason number one was so much of healthcare is shaped by politics. Now I'm going to show how old I am.
Okay.
There was a big debate about whether or not we should have DRGs at this point in time.
Okay. Yep.
And so being aware of public policy, being able to understand how to influence public policy, this priest was suggesting would be a big part of being a healthcare leader. And the second thing that he encouraged me to get into politics as my major was that it also gave me the opportunities to sort of tailor make my educational curriculum towards healthcare administration. By that, I was able to do certain things. I was able to deviate out of the program a little bit, did a lot of business administration classes, but then took some psychology classes, the psychology of aging, and some other different things, as well as doing an independent study, studying DRGs, and also doing a focused internship on getting exposure to healthcare administration. So it gave me an opportunity. It was a very small school, which was also appealing how I ended up at Allentown College. I felt I needed that individualized attention. And so going there brought all this together for me and actually led me to graduate school because I did my internship, and the sister who I did the internship with advised me that I should go work on my master's right after undergraduate school, get it as soon as possible. She thought that that would be the best kickstart into a healthcare administration career. So I followed her advice and did that right after graduating from college.
What was it that got you thinking as a young man, coming to college that you wanted to do healthcare? Because what we find here at UNH, where I teach an undergraduate health administration program, is a lot of kids aren't even really aware of the field. Like they kind of have to get here and discover us. And that's actually like when I go to, like, I was just at a conference a few weeks ago with other programs like ours, and that's kind of a common theme we were talking about. So what was it that got you the bug as a young man?
I might say fate. So I showed up. So I don't know if it's still true in high school, but in our high school, way back in the day when I was in high school, you had to take health as a course. You dreaded it because it was like 2 quarters of the year that you couldn't take gym, that you had to take health. And so I took health, had to take health. And one of the things that the health teacher decided was he wanted everybody to do a sort of a report or paper on a different healthcare career. So what he did was he scattered a bunch of brochures about different healthcare careers on the table. I actually came in a little bit late to class. So when I got to the table, there wasn't a whole lot left. I kind of vaguely remember respiratory therapy, which honestly did not appeal to me. There was still nursing on there. I knew I wasn't cut out for that. And then there was a guy in a suit, and it was the American College of Healthcare Executives brochure.
Uh-huh.
And I read that and I thought, that's what I'm going to do my report on. Now, that did not convince me that this was my career. This was my junior year of high school. Gosh, it was a long time ago, Mark, but I'm remembering it very well. Um, sadly, but not too sadly, later that year around Easter time, my grandmother, who was at that time 89 years old, had an episode where she got dizzy, fainted, got rushed to the hospital, brought to a very good hospital in Wilmington, Delaware. But I think what really dawned on me was, she was an immigrant from Italy. She had a tremendous fear of the hospital. Not only did she, but my mom and all of her sisters, and she came from a very big family, thought that you go to a hospital to die and it's a terrible place. And, oh my gosh, mom's in the hospital. This is the worst thing that could have ever happened. And I thought, well, does it have to be that way? I'd like to be in a role that actually makes the experience for patients and families something that doesn't need to be feared, something that could actually just be a part of the life process. And I found that for me, because I absolutely do not have the aptitude to be a hands-on clinician, I don't have the knowledge and intelligence to be a clinician, that I found that this is my way of contributing to making healthcare the very best that it could be, or at least the small area of the world that I work in, to be the very best that it could be. I also was always attracted in my life to serving the vulnerable, the most vulnerable. And I saw my grandmother as being vulnerable for two reasons. One, because of her age. And then secondly, she was in a hospital. And it dawned on me that if you really want to find the most vulnerable, you don't have to look a whole lot further than who's in the hospital. There's a feeling of vulnerability when you enter a hospital setting, and I wanted to try and alleviate that and mitigate that as much as possible. And that, but I knew that from about the summer between my junior year, as my grandmother was recovering and I was spending a lot of time with her, the summer between my junior year and my senior year, I kind of knew that this was where I wanted to go. But I think at first I really was leaning towards long-term care,
Sure.
because I had seen this with my grandmother, who I was very close to, and it had a very profound impact on me.
Well, so you graduate, you go on to do your MBA at Widener University with a focus in medical services administration. You've done some research on DRGs, which did in fact come into existence while you were in college, actually.
Yeah.
Um, uh, uh, So how did you launch your early career? Where'd you go like after you finished all that?
Boy, it is so funny because now that I'm reflecting back, and you are making me reflect back, Mark, it's a good thing. I'm going to say fate again. So Widener had a very great Health and Medical Service Administration MBA program. I was so fortunate to be educated through them. Actually worked as a research assistant in the office for these professors. Most of the professors were full-time professors, incredibly academic, incredibly smart, really wonderful. They let me do a ton of regression analysis and correlation coefficient analysis about DRGs. A wonderful time in my life. But there was one teacher who actually was not a full-time professor. And he actually happened to be the CEO of Alfred I. DuPont Institute of the Nemours Foundation, which is a children's hospital in Wilmington, Delaware, which is where I grew up. And I was actually living with my parents at that time as I was going through graduate school as well. Well, he taught a class, and I believe it was healthcare operations administration. And it was the reality of here's the day in the life of a CEO that was just captivating to me. So, as fate would have it, I'm working in the health administration office doing my research, and the program director comes out and says, Tom Ferry, he was the CEO at Alfred I. DuPont, needs someone to do a research study on sports medicine for the Alfred I. DuPont Institute. Do you have any interest in that? I said, boy, that would be fascinating. He said, well, give him a call, set up a time to meet with him and see if you can work it out. And sure enough, we did. That led to a full-time administrative residency for a year, which was more than was required for my program, but something that intrigued me a great deal at the Alfred I. DuPont Institute. And I just loved it. Fell in love with children's hospitals right away. And again, through fate or whatever, I had been serving as the interim director of the ambulatory care services, and I then applied for that job and got that job and started my career in ambulatory services, which at that time I had no idea what that even meant, but found myself fascinated by the challenges of ambulatory services and got to learn a lot and grow a lot at the Alfred I. DuPont Institute. It will always have a very special place in my heart.
That's a great story, and one that I try to share with, or the nugget there of just this kind of luck, happenstance, and taking that opportunity has like really seems to have kind of been the launching point for your career. And I just tell my students that all the time, like if somebody comes and offers you an opportunity to do something, you say yes, you
Great
know,
job.
right? Like
Your antennas up for just the sort of the movement of the world around you, because sometimes you just want to join in that flow of it as well.
so this was not long-term care. At
No.
what point did you kind of let go of like the long-term care thing and be like, maybe I want to be in more on the acute care side?
Okay, fate again.
Yeah.
Let me go back to, I'm going to go back to college. So I told you that one of the reasons why I chose politics is I could design a whole semester internship that would count as credits, but I could design it so that it would actually be something that was moving me towards what I believe my career aspirations to be were. So I knew I wanted long-term care. Again, Mark, how these things happen. So I worked very hard to set up an internship for my second semester junior year at a long-term care facility in Center Valley, Pennsylvania. There was only one long-term care facility in Center Valley, Pennsylvania. It was a very nice place. When I was doing psychology of aging, I had gone over there to learn about some of the things that we were learning in the classroom. I had met with the administrator, was very excited. I left for a winter break from college with a commitment from the administrator. Well, you can start the second week in January when you come back up to college and stuff like that. You'll come here 2 days a week. He had signed off on all the different paperwork that needed to be done for the college. And so the first week in January, I call to say I'd like to set up a time, my starting time. Can I speak with, and I don't recall his name, Mr. So-and-so, who was the administrator of the long-term care facility that I'd been talking to. And they said, let me see if you can talk to Mr. Such and such. Well, Mr. So-and-so was no longer there. That
Oh,
long-term care facility had been bought out by a bigger corporation. So here I was going into my junior year now. The gentleman was very nice when I talked to him, and he said, this is not a good time to do an internship here. We're going through a lot of change. This just happened a week ago. I'm really sorry. And so now I'm faced with not having basically a course, second semester, junior year. I'm sure your students get worried about that,
mhm.
Mark. It starts looking like I'm not going to be able to graduate. So I scramble. I actually washed dishes in the community where the priest lived. And I was washing dishes, and one of the priests comes up to me, how's your semester looking? And I said, well, not so good. I'm a course short. And I tell him about my trials and tribulations with this long-term care internship. And he says, well, have you ever thought of hospitals? And I was like, I guess so. And he said, well, he had a sister who was a second vice president of Sacred Heart Hospital in Allentown. He said, she's wonderful. Why don't you give her a call and see what happens? Well, I did, and she worked out an internship for me for that uh, semester, and it was wonderful. It was a great exposure. It was mostly just a rotation around the organization to learn about all the departments of a hospital, and I was enthralled, so enthralled that she also then got me a job as, again, I'm going to show my age, a weekend messenger for on the evening shift of pushing around the cart to get medications to units from the pharmacy, get lab specimens back to the lab. No pneumatic tube systems at that time. You just walked it and pushed it. But what a great way to see a hospital, especially in off hours. And that really got me started on loving hospitals.
Well, that's neat. And another good demonstration. I'm gonna have all my students listen to this now because sometimes they're like, oh, Professor Bonica, what do you know about? I'm like, that's my whole life too. Like everything, there's been these like seemingly random moments that just make a huge
Yes.
difference. So you start your career in children's hospitals, and that is really a theme in your career. Um, so you're starting in Wilmington. Tell me, like, kind of. I know you eventually work at Children's Hospital of Philadelphia, one of the great children's hospitals in the
Amazing.
world. Um, uh, to tell me a little bit about kind of your early career, and you're a non-clinical leader. So there's challenges to overcome working with clinicians. What did you learn, in your early career, trying to manage healthcare, working um, with clinical counterparts? How did you learn your trade and become
Oh,
effective?
boy, a great question. And again, that takes me back a good bit. So I'm going to be perfectly honest. When I first started as the interim director of ambulatory care services, I was somewhat intimidated by the clinical leaders. Incredibly knowledgeable, incredibly bright, incredibly driven, worked very hard, and really. Just I had such immense respect for them that I do believe there was some intimidation that I felt. Not because there was any overt intimidation, it was just all within inside of me. And what I learned really early on is that they have great ideas, and really that I thought my role was listening to those ideas, coming back to them with, maybe we've refined that idea into something, and then basically creating a relationship of mutual respect. I think the first thing I learned in healthcare is something that guides me to this day, is that healthcare administration is all about relationship building. And you better figure out how to build relationships as a non-clinical leader in a very clinical area. Um, you better figure out how to make those relationships work with clinicians. And I think that has to be a mutually respectful, trusting relationship. And early on, I realized that that was the only way I was going to succeed, was them seeing me as a partner, never as an obstacle, and certainly never as a pushover. But seeing me as a partner that brought a different type of expertise to the conversation and to the organization. The beauty of Alfred DuPont was it was small, and yet it was going through dramatic change. At that time, they didn't bill for any of their ambulatory services. It was all free of charge because they figured it was largely an orthopedic hospital. If a child has scoliosis, we'll make our money on the surgery and all the work afterwards. So don't worry about the ambulatory services. Well, it was a fascinating time in the evolution because they were starting to bring medical subspecialists on as well. Well, sorry, that same argument doesn't hold true of like for rheumatologists. They're not going to do surgery on that patient. So we started to put in place billing for the services that we did. So I could bring an expertise of the business part of it and how the business part of it actually makes the medical part of it sustainable. And they were also very interested in the research. So we learned together that, when we work together to try and create the best product that we possibly can, it actually gives us a true springboard to fulfilling our three-part mission of research, education, and clinical care. And so we just constantly brought that together that, we do these things because we have a pretty lofty mission and we need to do these things well so that we can continue to preserve that. And so I felt that we created very trusting relationships, very respectful relationships. And I guess, it really helped shape me as a leader and an individual as well. And, I could bring what I had come to healthcare administration, what drew me there, that of patient family centeredness, I could bring that perspective as well, which one of the beauties of children's hospitals is they truly are the leaders in patient family centered care. And so it was just a natural and a great learning experience for me to truly understand how patient family centered care can impact care delivery and also make for even more satisfying experiences for staff and for the medical staff as well.
You hit a couple of really interesting things. One being family-centered care. I mean, the idea of patient-centered care just in general is something that, as my father was trained as a physician around the time you were starting your practice, and I've had conversation with him about his training and how he was told, you're the physician. When you walk in the room, you tell them how this is going to go and what's going to happen. And that's a radically different paradigm than what we hopefully are working with today, with a much more patient-centered, family-centered. I mean, family-centered, of course, for pediatric care, but patient-centered care. That's a really interesting. That was kind of a paradigm shifting
Oh,
moment
absolutely.
then.
It was. And, at that time, again, patient family centered care was really in its infancy. It was just starting to take off. This would have been, the late 80s, Mark. So it was just starting to take off. And you mentioned the Children's Hospital of Philadelphia. They were already way out in front of everybody. For us at the Alfred A. DuPont Institute, it was something new because, again, it was this the Alfred A. DuPont Institute was really designed around physician needs more so than patient needs. We would have sometimes, 120 patients scheduled for an orthopedist in a day. And basically they would start at 8 a.m. in the morning and, the last patient would be finished at 6 p.m. at night. Well, yeah, that worked well for the orthopedist. He or she never had to worry about, is there a patient in the room waiting for me? Didn't work so well with a family with 3 kids that are trying to lug them to this appointment and they're there for 8 or 9 hours. So putting in real scheduling systems from a patient family perspective was really the starting point for me. It wasn't until I got to the Children's Hospital of Philadelphia that I really started to learn about the essence of patient family centered care is really that the patient and family are partners with the healthcare provider in their healthcare. I mean, honestly, obviously, 99% of the time they spend is not going to be in the presence of that healthcare provider. The impact that is really going to have the most impact on their health is what they do outside that 99% of the time. And that's how that patient and family better be a partner in this, or everything that the provider does is really for naught because it won't be followed up if it's not a partnership. So we learned a lot over time, but we really started with really more, I guess you would even say, of patient focused, of trying to just say, having 100 people come in at the same time backs up our registration process. It backs up this. Radiology can't keep up. Maybe we can do things in a different way to improve the experience for patients. And again, the risk was, well, what happens if I go to an exam room and there's nobody there to see me because you've created this scheduling program that just doesn't keep my rooms filled. And we got through all that because of great physician leadership who understood, we have to change, especially if we're going to start charging for this. You can't expect people to say, yeah, we'll pay for this and we'll just wait 9 hours to see our orthopedist.
Yeah. Yeah. And so that would brings me back to my second point from your story, that you're talking about how you weren't billing for ambulatory care. And this just fits into your story about DRGs and the DRG implementation. I mean, healthcare really started as you were kind of coming into your career, healthcare really started pivoting, or hospitals started pivoting away from an intense focus on inpatient, and the ambulatory side became much more important.
Mm-hmm. And I was so lucky to be there at that time. And I'll just explain how rudimentary our billing process started off. And it's kind of funny. At that time, there were things called chart out guides that would print out so that you would be able to pull the charts for patients. Thank goodness for electronic health records. You don't do that anymore. But the chart out guide would print out in medical records and they would have all these chart out guides. They'd pull the chart, put the out guide on the front of the chart. So what we did was we actually put the billing information on the chart out guide. And so basically we would say it would already know if it was a new patient visit or an established visit, but then the clinician would circle the level of care that they did. Somehow we would try and make sure we got an out guide back for every single patient, not in an automated way, but just in a manual way. And then, it was fun to watch the evolution of creating real encounter forms, creating a missing charge reconciliation process, and actually putting structure in where there had been no structure at all, and starting at such a rudimentary field, then to get to a place where, every encounter form was numbered. At that time, it was not even in an automated way, but then you knew if there was a missing encounter form in the sequence and you had to find that encounter form. It was great to be so small that you could dig into the details and really understand at a very deep level what it takes to build a system.
Wow. That's amazing. I mean, I'm really enjoying kind of thinking because I lecture on these topics and like kind of the historical changes, and it's wonderful to hear.
So much
Um,
change in so really little time,
yeah,
honestly. I've
yeah,
had about 30 years. And I mean, we're facing another critical time in Vermont hospitals of, oh, you have to find a way to be sustainable, et cetera. Well, the history of hospitals and healthcare, we've always had to find a way to be sustainable and always will have to. But the reality is we keep finding that way. This hospital's been here for 120 years. Uh, there's been some challenges in those 120 years, just as dramatic as what we're facing today.
yeah. So you continued your career. When did you transition to Children's Hospital of Philadelphia?
So right after my time at the Alfred A. DuPont Institute, a friend of mine had called me and said he was actually working at the University of Pennsylvania Health System and said, we're really starting to put an emphasis on ambulatory care because of
Mhm.
DRGs. Would you be interested? There's a director of operations role with the University of Pennsylvania Health System. Would you be interested in that? And so I met with the people at the University of Pennsylvania Health System. And at that time, I was thinking, I'm not getting experience with DRGs because it never hit the children's hospitals.
Mhm.
And I probably need experience with this. I probably need to expose myself to a different type of organization than the children's hospital that I'm in to see what really is my career pathway or my passion for the future. So I decided to take the role at the University of Pennsylvania Health System. And boy, did I find a very different environment than where I was.
Yeah,
So I learned a lot about an academic medical center. And there were good, just like with every organization, there were good parts of it, and there were some not so good parts of it. The not so good parts of it was highly political and very entrenched in the way it was doing things. And you learned very quickly that to move this mega organization, even just a hair, it took a ton of effort to do that. But I also learned and enjoyed uh, being in the sophistication of an academic medical center. So I really loved that. I actually learned one of the most valuable leadership lessons that I learned. My job as director of operations for ambulatory services was a corporate role. I had responsibility for, I had accountability for delivering certain things, but I had no authority over the areas that were going to be delivering that. The ambulatory at the University of Pennsylvania Health System was really a clinical practice design. And the clinical practices, it was made clear to me, were the purview of the department chairman and their team. They ran their clinical practice. But my job was to get them on one registration system, one scheduling system, one billing system, standardize medical records, standardize a whole host of different things. And at first I thought, well, I can do it because I'm the director of operations. I've got this great title. And all I have to do is say, I'm the director of operations and we're going to do this. And I learned very fast that that title meant nothing to anybody. And that actually I learned, and I think it was Dwight D. Eisenhower who said, great leadership is not getting people to do what you want them to do. It's getting them to want to do what you want them to do. And I learned very early on that it's all about influence. It's never about command. It's never about demanding change. It's about influence. And it's finding and articulating, here's what's in it for you if you make this change. And that was the most valuable lesson I ever could have learned. I remember it to this day because I was in a very highly political organization that was going through massive change. This corporate entity was new and the practices were not too excited about it, yet I had to get things done. So why I went to the Children's Hospital of Philadelphia was it was sort of the blending of these two things that I felt passionate about, uh, children's healthcare and an academic medical center. What I loved about the Children's Hospital of Philadelphia is that it's really great to be sort of the the dog leading the pack instead of following the pack. And the University of Pennsylvania health system was very much like that as well. There's something very exciting about saying, let people respond to our strategy instead of saying, you know, they're doing this. How do we respond to that? And actually be the leader in that. And no doubt about it, the Children's Hospital of Philadelphia was the leader. It still is a major leader in that. And that's what attracted me there. And the beauty of the Children's Hospital, it's an environment there like I've never seen. I think if you go to Boston Children's, you would see very similar environments that really caters to the unique needs of children and their family members. I mean, again, I learned a lot about patient-family-centered care, having family resource centers and the importance of having that in a children's hospital, eye-opening, yet also very much shaping my thoughts for the rest of my career.
So you were at Children's Hospital of Philadelphia, but in the early 2000s, you make a pretty big jump. You went down to the Children's Medical Center of Dallas. So that's a long way away. How did you want so how did you wind up making that jump?
So I think two things happened. There was some leadership change at the Children's Hospital of Philadelphia in a good way. Well, in just a way. Great new leaders came on board, a new chief executive officer. Then the chief operating officer left, and the chief operating officer was somebody I was very close to. So I actually reached out to my first boss at the Alfred I. DuPont Institute and
Okay.
said, hey, you know, I don't know if you're interested, but our chief operating officer is going to resign. You may want to look at the Children's Hospital of Philadelphia. He was from the Philadelphia area. He was working in Oklahoma. From my very myopic view of the world, I thought whoever would want to be in Oklahoma. So I reached out to him and he said, funny you should ask. I need to ask you if you would be a reference for him because he was up for the chief operating officer at the Children's Medical Center Dallas. So I did. I was his reference, talked to the CEO about him. One thing led to another. He got the job and he started around Labor Day. And by election day, my wife and I were on a plane down to Dallas, Texas. First time I ever saw Texas, to interview for a job that actually didn't exist. But they knew they wanted to put a big emphasis on ambulatory services. I hate to say it this way. At that point in time, and it's probably still true today, if you had experience at the Children's Hospital of Philadelphia recently, other children's hospitals were just in a rabid frenzy to try and hire you. And so I looked at the opportunity, and what I saw happening at the Children's Hospital of Philadelphia is we had grown very rapidly. We had expanded a tremendous amount. We were building sites all throughout the tri-state area. It was a fascinating, incredibly exhilarating time to be there. And as the new CEO came on board, his mindset was going to be, you know, we probably need to stabilize what we've done and take a pause in this rapid growth. And I think that was very logical and absolutely the right thing to do. But I was very young in my career and I realized I like the growth. I like the exhilaration of building and acquiring and just growing. And that's exactly what was the opportunity at the Children's Medical Center Dallas. It was a completely unknown entity at that point in time, but it was an absolutely hidden treasure. It had a great relationship with the UT Southwestern physicians, so they had an incredible academic tie. had tremendous philanthropy supporting them, was in an area that was just exploding population wise. And much like the Philadelphia area, the population wasn't growing in Dallas. It was growing all around Dallas. And now the issue was, how do you get out to those areas? Is exactly what I was doing at CHOP. And it was that exhilaration and then getting back connected with my first boss, who is still a good friend to this day, was what appealed to me. But it was hard to move halfway across the country, and I'd grown up in Delaware, so it was a big change, but it actually worked out well. It was a great place for our kids to go to school all the way through high school as well in the Dallas area.
Well, that's your story is a little bit like mine. I, grew up here in New Hampshire or New England area, and my first duty assignment with the military was in El Paso.
Oh,
So
wow.
my wife and I jumped, like you, my wife and I jumped on a plane after we graduated, after we got married, and flew into El Paso, and that was our like seeing El Paso from the air was our first experience of Texas together. So anyway, yeah, so I mean, really, I love this through line of ambulatory care that like you just kind of jumped into it. Like it was all goes back to that moment where you said yes to doing some research and just keeps weaving through your story. So
Yes.
so you're VP of Ambulatory Services at Children's Medical Center in Dallas. And then you move on to uh, JPS Health Network in Fort Worth, kind of continuing your ambulatory care emphasis. And I want to just kind of fast forward first, and then you become CEO of Covenant Women's and Children's Hospital at Lakeside Campus in Lubbock.
Lubbock.
Um, was that your first? That was your first CEO opportunity?
That is correct.
Okay.
That was my first, and I think that's what intrigued me of going out there, and also getting back into Children's Hospital. JPS was a
Mhm.
county hospital, and in Texas, because they don't take the Medicaid expansion, there's these patients that are called county patients, basically uninsured patients that don't qualify for Medicaid, because they didn't take the Medicaid expansion, that really were then to be served by the county hospital. Again, my desire to be involved with the most vulnerable, I saw this as a very vulnerable population, but it was largely adult. There was a little bit of pediatrics in there. So to get back into a children's hospital, this was my first foray into a faith-based organization as well, Covenant
Okay.
Health, which was also important to me. And then to be a CEO within a health system, I thought was the right way to get my first experience as a CEO. I didn't have the total responsibility because as a health system, you're sort of protected by the umbrella. I actually reported to the CEO of the system, the regional CEO. So there's some protection in your decision making. So as I was still learning, I felt that that was a good thing for me. So for those reasons, we went out to Lubbock, Texas, probably more like El Paso than Dallas is like El Paso, but another great community, another great way to work with another tremendous medical school, Texas Tech University Health Science Center. We worked very closely with them. And again, a time of great growth, challenge, and evolution that was just a very exciting time for me to be there.
Yeah. So what was it like becoming CEO? What were your kind of like big learning moments?
I think the first thing I learned was, and maybe this was also a Texas thing, that was very true in Lubbock. That so I consider myself somewhat of a free thinker. I do like to work in the realm of vision, and so what that means is that you'll be in a meeting, and I have no apprehension of saying, something that comes to my mind of saying, so have we ever tried this, or we should do something like this? And when you work at the Children's Hospital of Philadelphia or at the University of Pennsylvania Health System, and you say something like that and it's not a very good idea, people tell you right then and there, yeah, not such a good idea. That'll never work here, etc. Well, here I was at now CEO in Dallas, which maybe not, has better manners than the Philadelphia area. I won't make any judgment call there.
Oh,
But so
Philadelphia is known for its manners. As I've always.
So I would say things like, what about this? And people would not push back and say, oh my God, you got to be kidding. They'd actually go out and start implementing things because the CEO said this and we should do this. And so I remember one time saying, why would anybody do something like this? And it's like, well, you suggested it in our leadership meeting that day. You said we should do this. And it was like, oh, yeah, that was just a thought. I didn't mean that we should do this. So I had to learn really quickly that I had to say, I'm just thinking out loud here and say something rather than, here's something and you better go run with it.
They
So
were
I,
trying to please you, and they were
yes.
just running out there.
And I think that was the title that did that, oh,
Yeah.
the CEO said we should do this. And it's like, yeah, the CEO was just engaged in a brainstorming session with you. And, we want to take an idea and then really analyze it and then really try and make it work effectively if it's the right thing to do. So I had to learn that, anything that comes out of your mouth as a CEO, boy, people listen. And probably more important, people listened by your actions, and that everything you did, you needed to be consistent with what you said your values are. So every action needed to be that way. So, if you wanted a patient family centered organization, I would show up at our patient family advisory boards. I would go to those meetings, but I would also know I'm not there to dominate the conversation. I'm there to listen. And so I really learned a lot that, you have to model the behavior you want as a CEO. And you also always have to be cognizant that everything you say is going to be interpreted a million different ways. So you have to have very clear communication, clear expectations. And so it was a great thing to learn pretty rapidly and pretty fast that, you better be authentic in your leadership because people will find it out very quickly if you're not.
Now, you also held at the same time the Chief Culture and Experience Officer. Is that correct? No.
No, so there's a little bit of again, I'll say it's fate, but a little bit of a curveball that came into my life as I was the CEO of the Women's and Children's Hospital and absolutely loving the job I was doing. I got diagnosed with cancer
Oh,
and
wow.
needed some treatment, some surgeries, and lots of different things. And I tried to come back from it as CEO. And when I came back, I knew I couldn't. My health had to be my first priority. I had to really focus on my health. I couldn't work full time. And I remember sitting down and describing this to my boss, the regional CEO, who just an unbelievable person, said, well, what would you like to do? And I kind of jokingly said, I'd like a part-time job. And he said, let me work on it. It's like, what am I going to do as a part-time job? So he created this role of Chief Experience Officer, really for the patient family experience, and Chief Culture Officer for two reasons. Well, probably for three reasons. The first reason, he, for some reason, wanted to keep me in the organization, and he was just a good man and was determined to do so. Second reason is we actually, the Women's and Children's Hospital was doing incredibly well with patient satisfaction scores. So he wanted that to be something that could be more pervasive throughout the 7 hospitals within the system. And then the final reason, the culture reason, was that we had a very unique, so Covenant was part of the Sisters of St. Joseph of Orange, California system. So a weird thing, you've got this West Texas system of 7 hospitals, and then you have these California hospitals. Well, the Sisters of St. Joseph of Orange then merged with Providence Health System out of Renton, Washington, which is one of the largest health systems in the United States. And so he was very concerned that the culture that he had worked so hard to preserve within West Texas was going to get eaten up by really this monster from Renton, Washington. So he really wanted me to focus on that. I actually happened to be an ordained Catholic deacon. And so he wanted to make sure that I was working on the cultures that the sisters really had started, that we didn't let that get absorbed into something else. So I did that, but I also did a lot of special projects for him. And I did that on a part-time basis for a couple of years while I was getting treatment and recovering from surgery and some of the harsher treatment that I had had. And actually, again, I was very fortunate. It was a great time to be there. I hated giving up my role as CEO. I knew I couldn't do it justice by the physical demands of it, which there are many physical demands. It's not lifting a lot of weight, but it can be exhausting. And I was getting exhausted very easily at that time of my life. So that's why I did that. And so it was a separation. I left my role as CEO and became Chief Culture and Experience Officer.
Wow. I mean, a couple of thoughts. I mean, one is just like what a great leadership um, decision by your regional CEO to like,
Amazing man.
you know,
Amazing man.
yeah, to keep you to show you that respect, but also to take advantage of what you'd been doing. So what did you do that had changed the culture of the organization in such and gave such positive, I mean, patient experience scores? I mean, like what was it that you were doing with your team that really that your regional CEO was looking to replicate across the system?
So we were small at the Women's and Children's Hospital, but it's really interesting, Mark. Actually, I believe it's still true. I don't work in a children's hospital anymore, but um, I've always heard and I've always believed that to get good scores on patient satisfaction surveys are actually more difficult in children's hospitals because the people that are filling out the surveys are parents, and we may, as parents, tolerate an awful lot of things about ourselves, but boy, if you're not treating my child right, you take a very different viewpoint. So we actually had a big ditch to dig out of in terms of our patient satisfaction scores. So creating a patient family centered approach, having a patient family advisory board that helped us shape the organization and how we did things, putting a spotlight on really looking at the data that we got, trying to find different ways of getting feedback from our patients and families, creating an office of the patient family experience that really brought things under one rubric of analyzing our data, actually doing sentiment analysis as well, not just looking at the numeric scores, but looking at are there sentiments in terms of the comments we're getting, whether that be on our surveys, through Facebook, through complaints, through any other means. Are there themes that we need to be addressing, and really creating an organization-wide approach to taking this feedback seriously and also helping us shape what we're doing. I think that when you really look at patient family experience and providing great service, you really need to clearly articulate behavioral expectations, train to those behavioral expectations, monitor those behavioral expectations, and also reward and recognize how things go. So putting those components into place of saying, we're taking this very seriously. These aren't just things on paper. We're actually going to train you about these things. We're going to do things to motivate you to truly provide the very best experience for patients and families possible. And it all started with clear-cut behavioral expectations, and then ultimately became you hired based on those values as well. That, if you may have all the skill in the world, but if you don't hold those same values, if you don't approach patients and families the way we believe patients and families should be approached, you're not a fit here. And so that was what we were trying to push through. Culturally, we did some things a little bit different with the culture in the Women's and Children's Hospital because it was small. And these are things I still do today. I actually host coffee with Chris every week. I know it's hokey. I was in Lubbock, Texas, Mark, so I could be hokey. And the coffees with Chris, 1 week a month, it would be with frontline staff randomly selected from the organization. 1 week a month, it would be middle managers randomly selected throughout the organization. 1 week a month, it would be providers who were randomly selected throughout the organization. And 1 week a month, it would be, in our case, in a children's hospital, family members who were randomly selected, that I would just go in, no agenda. It's just a listening session. I'm here to hear what's on your mind. What can we do to get better? What questions do you have? So we would do those things. We would actually have regular town hall meetings to keep communication going. I would send out every Monday, and I still do this today, a Mission Monday. How can I connect our work this week to the mission of the organization? And those were the types of things that I was doing on a small scale, that the desire was to try and get that out on a bigger scale, larger scale throughout the system.
Well, those are all great. Coffee with Chris is awesome. That's a great, that's so much fun. And there are great values that I feel like, I think Coffee with Chris is a great example of the kind of things you learn from the culture, different cultures you get immersed in, right? Like maybe you wouldn't have thought to do something like that had you not been to Lubbock or, and seen their values, right?
Absolutely.
That's just one of the great things. And from my military career, having been kind of all over the country and just seen the different ways people live and relate, it's a, kind of neat opportunity. So in 2018, you moved on now to the West Coast to be the administrator for Shriners for Children Medical Center in Pasadena, California. So I assume that at that point you had recovered and kind of wanted to get back in the saddle.
Yes, I had recovered enough that it was time to really give the full-time work and full-time responsibility another go. Shriners and Southern California were intriguing to me for two reasons. One reason would be a physical reason. So my diagnosis was such that it wasn't a good diagnosis. And honestly, the feeling was that, yeah, 5 years is really probably never going to happen for
Oh, wow.
me. But at first it was 4 months and we got past that hurdle. But I was really worried about the 5 years, to be perfectly honest. And my wife grew up in Southern California. She still had a lot of family and friends in Southern California. Again, fate. Somehow when we were in Lubbock, Texas, our daughter, who was going to nursing school at Covenant, was with us in Lubbock, Texas. And so she had support in Lubbock, Texas when we were going through some bad times. If, they were right in their predictions that 5 years was going to be the end of it all, I felt compelled to make sure there was a support structure for my wife. Because kids were now gone, they were all over the place. So I thought that was a strong motivating force there. The other thing is that I really went back into the ambulatory world when I went back to Shriners. And so I also felt that as a administrator, kind of CEO again, I wouldn't have the 24/7 demands of a hospital, acute care hospital. So I thought this was also kind of a safe place in terms of my recovery to go to. And the mission of Shriners is fantastic. It was again uh, re-entering a children's hospital environment or children's healthcare environment, which was very important to me. So for those reasons, we made that decision. But it was really also, I was part-time working, and I really wanted to get back to full time, but I didn't want to do it in a way where I jump out to full time and it just didn't. I couldn't cut it. So I thought that this was a really good stepwise approach to getting back to where I ultimately wanted to be, which is the CEO of a health system with an acute care hospital.
So this facility is actually an ambulatory only facility.
It was actually two facilities. There was one in Pasadena, which was a large ambulatory facility with surgery, physician office visits, PTOT, orthotics. And we had another facility in Tijuana, Mexico.
Oh,
Uh,
wow.
Again, my desire to work with the vulnerable, very, very vulnerable in Mexico as well.
Yeah.
I was overseeing these two facilities, which was great. It gave me challenge. It gave me some exhilaration and the site in Tijuana was expanding so rapidly because the need and the demand was enormous. And in Tijuana, it was completely free care in Tijuana. And such needed care. People were coming from all over that region of Mexico to be seen in this outpatient facility.
Wow. Wow. I mean, what a unique opportunity to manage a facility that, it's not that far away geographically, but it is literally in a different country.
It-
So you're dealing with a whole different set of laws and culture
oh, yes, and language.
and
I
language,
don't
right?
speak
Yeah.
Spanish very well. Fortunately, I had a great manager of that site who spoke English and Spanish very well. But it also is interesting that this happened during COVID as well,
Yeah.
for almost a year and a half, I couldn't even get to the site in Mexico.
Wow. I
So
mean,
that,
I was going to kind of
oh,
facetiously say it's a good thing that nothing big happened during the 2018 to
oh, oh,
2022 period.
Oh, and then they also tightened the border so much. It was relatively easy getting into Mexico, but it could
We
take
couldn't get back up.
hours to get out of Mexico back into the United States. And
Yeah.
even though we would get a medical designation, but we still had struggles getting back into the country. And that was very tough. I mean, doing everything with Zoom and Microsoft Teams with our group in Tijuana was very difficult.
Did you have, I mean, how much movement back and forth? Obviously, that got dramatically reduced during
Right.
COVID, but like by design, how much back and forth was there between the facilities?
So great question. Honestly, what we fortunately um, did right before COVID, one of the first things that I did when I got there was so Shriners Pasadena, before I got there, switched from an inpatient hospital to this outpatient facility, ambulatory facility. And they did it on the back doorsteps, basically, of Huntington Hospital in Pasadena, a big hospital.
Okay.
So they had this inpatient relationship. We also had a great relationship with the Children's Hospital of Los Angeles. Tijuana had nothing. They had this ambulatory facility, and that they would try and ride the coattails of coming into Huntington Hospital or to Children's Hospital Los Angeles. We decided very early on, no, we need to have something in Tijuana, and we found a very good hospital in Tijuana who wanted to take care of children and wanted to work with us on that. So fortunately, prior to COVID happening, we had established this relationship. So really, these kids were staying in Mexico, getting cared for in a very good hospital in Mexico, not having to come and then stay in the Ronald McDonald House, which was a big nightmare during COVID. I mean,
Yeah.
a very enclosed area. It was, again, maybe fate again, that fortunately we had done this prior to COVID hitting, because if COVID had hit, I don't know what we would have done. Those kids would not have been able to come across the border. If they did, I don't know where they would have stayed. The Ronald McDonald House was closed. I don't know what we would have done. Or we would have pushed off that care. Most of it was elective care. But man, that the thought of that, these were kids with terrible cleft lips, terrible orthopedic problems, and terrible burn problems. I don't know how you can push off that care for an undetermined amount of time. So we were very fortunate that we had done that. And so that care stayed in Mexico. And it was interrupted to a certain point, but Mexico took a very different approach to COVID than the United States did. So there was different waves of when it was very high in Mexico and when it was very high in Southern California, the impact of COVID. So we learned a lot in Southern California. We applied it in Mexico, but the laws that the government put out were not the same. So even though you did a lot of things to try and prevent the spread of COVID, as soon as you left the walls of our institution, it was sort of fair game in Mexico. You could do whatever. Restaurants weren't closed. Nothing was really closing down. So people didn't have to wear masks, and you were seeing these very elevated levels of COVID there constantly.
Yeah. I can't imagine trying to lead. I mean, so that's a subordinate organization to the one in Tijuana. So like you're trying to help them, but you couldn't go there. I mean, that's
And
amazing.
Zoom and Microsoft Teams only go so far, I
Right.
believe.
Yeah.
So as soon as we could go back there, we did. But it was probably, gosh, Mark, probably about a year and a half that we couldn't go down there. Now we would talk. So another perfect example, the manager lived in the United States. So she was crossing the border. She lived just on the border of the United States and Mexico, and Tijuana's 10 minutes over the border. So she was crossing the border every day. So when we got the vaccine, we gave her the vaccine. There was no vaccine in Mexico. And, we couldn't bring the staff up from Mexico. We couldn't send somebody down from Mexico with the vaccine. So she was vaccinated and got the booster, but nobody else did. So she would stay connected. There were times where she had to pick up supplies and she would come in. So at least my connection with her was still good. It was the staff, the physicians,
Sure.
really couldn't stay that connected with.
Wow. What a
Fortunately,
challenge.
she was a very gifted leader, and you could trust and empower her to
Yeah.
really carry the ball.
Yeah. So I know we're such a fascinating conversation, and I don't want to miss out on where you are now. So let's talk 2022. You made another jump back to the East Coast, where you became the CEO of Brattleboro Memorial Hospital in Brattleboro, Vermont.
Yes.
What precipitated this move?
Well, I guess the first thing was, we managed through COVID. We weren't through COVID at that point in time in 2022, but it was getting better.
Yeah.
But we had managed through COVID at Shriners. And my job at Shriners was actually to really focus on keeping everything within the four walls of our facility as safe as possible. Here was by far the biggest public health crisis that I believe I will ever experience in my career.
Knock
And
on wood. Let's hope.
God, yes. Um, and I felt like I wasn't doing a lot for the community. Not me, but my team did a great job of keeping people very safe within the four walls of Shriners. That wasn't a lot of people. All around us, I mean, at times, Southern California was the epicenter for the COVID spikes.
Yeah.
And here, Huntington Hospital was fighting it like crazy. Everybody was fighting it like crazy, and I wasn't. So I felt this pull to be back in maybe a more community hospital setting. Community hospitals are under siege right now, not because people don't like them, just because the financing and the challenges that are associated with them. Small rural community hospitals like Brattleboro, Vermont, are really under siege. And so there was this part of me of feeling a calling to come and help create a sustainable pathway for Brattleboro Memorial Hospital. I also, my mother, thank goodness, is still alive and doing well in Wilmington, Delaware. During COVID, it became very clear that God forbid something happened to her, it would have been next to impossible to get there in any timely fashion by plane from Southern California to Wilmington, Delaware. That created a feeling of vulnerability that I didn't like, at least being in Vermont. It's a 5.5, 6 hour drive down to Wilmington. I can control my destiny and get there.
Yeah.
So that was intriguing. And then when I came out here, I just fell in love with the beauty of this area and the people. The people are fantastic. This area is absolutely gorgeous. It won me over minute one. And I will say, I was most recently in Southern California, obviously. And the day that I did my on-site interview here, it was 6 degrees. It was in March. There was still snow on the ground. And I remember one of the board members came to pick me up at the hotel, and they said, "You're coming without a top coat?" And I was like, "I live in Southern California. I don't have a top coat." But even though that was the way we experienced it, it was, I mean, you couldn't help but be just captivated by the natural beauty around this area. And we fell in love with it. It was kind of nice not to see traffic like we saw in Southern California. So there were a lot of reasons to come here, but most importantly, I think I felt again, and maybe I keep saying fate, but maybe it's really a response to what I believe is a calling. This is where I need to be. I need to be here to fight for the survivability of this community hospital. And that's a fight I really wanted to take on.
Well, that's terrific. So let's quick for folks who are not familiar with Brattleboro, where is it? What do we need to know to understand kind of the community that you're serving?
So it's on the virtually the most southeastern tip of Vermont. So it actually borders both Massachusetts and New Hampshire. But we get patients from both of those states. We get staff from both of those states. Brattleboro is a very small community. I think it's 16,000 people in the city, but it's actually a really nice downtown, great restaurants, really good things. We have an international event here, the Harris Hill Ski Jump, that people come from all over the world to compete in. It's really a great place to be, and everything is accessible. I think we were both talking about our fondness for sort of the seacoast and even the Maine beaches, a couple hours away. I think we talked about Bar Harbor. I think that's about 4 hours away. Haven't gotten there yet, but having all these things within a drive, Boston, 2.5 hours away, I mean, have just been sensational. People are great. It's an older community. I think one of the things that is a challenge from a healthcare perspective is Vermont is by age the second oldest state in the United States. Only Maine has an older chronological age average than we do. And Windham County, which is where Brattleboro resides, is the oldest county and the second oldest state in the United States.
Wow.
And the healthcare needs of the elderly are very different than that of other parts of our population. And when we say we have an aging population, it's not just the over 65, it's the over 75, the over 80 that is growing rapidly. A lot of chronic illnesses changes the way you really gear your healthcare delivery system a great deal. But interestingly, tying it back to children's hospitals, the need for patient family centered care and patient family involvement is almost identical to the way it is with children. The sad thing is when you're dealing with the older population is they may not have family members involved. And that's when you see some difficulties there. So that's brought me kind of full circle. Maybe all my life and all my career has been getting me ready for this challenge. I don't know. I hope so. But we're enjoying the challenge and absolutely adoring the community that we're in.
That's an interesting point, that there is a similarity between serving a very young population and a very elderly population in the sense that both of them need somebody to help with the decision making, and it becomes
And
more
caregivers.
complex.
Yeah,
And care,
yeah.
yeah, yeah.
It's
Wow. All right.
it kind of the healthcare cycle kind of comes full term, I think.
Yeah. So briefly, tell us a little bit about Brattleboro Memorial. You mentioned it's 120 years old, which is pretty amazing. What else?
It, not many hospitals last that long. It was born out of love, a love affair between Thomas Thompson, who was a businessman in Massachusetts, loved to take trips into Vermont. He fell in love with Elizabeth Rouse, who lived here in this area. But more importantly, they fell in love with this community. And so Thomas Thompson created the two of them created the Thomas Thompson Trust, which does an awful lot of good for this area. And one of the things that they wanted to do was support charitable organizations. It was because of them that Brattleboro Memorial Hospital started. It was through donations from the Thomas Thompson Trust. They actually bought the land that we're on. So at that time, it was born out of a love for this community and for a singular purpose, and that was to make the health and lives of this community the very best that they could be. 120 years later, that singular purpose hasn't changed. We still exist because of a love for this community, and we exist because we're here to make the health and lives of the community the very best that they can be. How we do that has changed dramatically. So we have 7 new key strategic priorities that are very different than what they were looking at back then. They were just looking at, how do we take care of broken bones? How do we take care of, this? What should we not take care of? What, all these different things. How do we get nurses? So all those challenges that they went through built a platform for us, but now we're taking that to a whole new level of actually really transforming into a population health management organization and not just a hospital system. So a lot has changed in 120 years, but not the reason why we're here.
Sure. So Brattleboro Memorial is a 61 bed, not-for-profit, still independent,
Still independent, yes.
which is pretty remarkable.
It is pretty remarkable.
Yeah. So a smaller community hospital, but
Very
serves an important part of that community. You mentioned, strategic priorities. Can you share a little bit about you talked a little bit about kind of that community health mission.
Yes.
How are you guys trying to integrate that?
Oh, fantastic. So one of our 7 key strategic priorities is elevate the health of the community. So that's kind of an odd goal and priority for a hospital. Hospitals typically get paid for people coming into the hospital. We want to actually keep them out of the hospital, keep them as healthy as possible, get them to be cared for as close to home as possible, maybe even in the home. So we actually have that as a key strategic priority. We also, in response to our community, we have a key strategic priority to infuse justice, equity, diversity, and inclusion into everything we do. Our community is somewhat diverse. Not incredibly racially diverse here in Brattleboro, Vermont, but we do have a lot of diversity based on sexual orientation, gender identification. We get a lot of immigrants from other parts of the world. Historically, we've gotten a lot, or most recently from Afghanistan, and now we're starting to get some from Ukraine. We also have a diversity in that we have a very larger than normal deaf and hard of hearing community. There was a wonderful school for the deaf, Winston Prouty, in this community about 2 blocks away from us, that brought a lot to school here, brought a lot of the deaf and hard of hearing community here for school, and they decided to stay here. And so trying to be an inclusive organization where everybody feels welcome and belongs here is another one of our key strategic priorities.
So talking about strategy, I mean, there's a lot happening in our industry now with, I mean, just technology, demographic change, which we've kind of addressed. What do you see as kind of the external forces acting on Brattleboro that are that you're having to take account of?
So, and I think it's not just Brattleboro, but probably anywhere in Vermont, probably anywhere in New England, Mark. Housing is a struggle, and housing prevents so one of the things that we're learning, and is a great thing to learn, is that social issues impact health. And we need to understand that completely, because if you're ever going to elevate the health of a community, you've got to be involved in the social issues that impact health. Housing is a big one. So it impacts us in 2 ways. The first way is it impacts us by those who have challenges of housing and may be unhoused. Obviously, that's detrimental to healthcare, and somehow we need to deal with that. The second way it impacts us is another, I think, truly repetitive theme of challenges throughout healthcare, and that is workforce. So it's great if we can recruit a doctor to come to Brattleboro, but if they can't find a place to live around here, we've got a real problem. And so housing is an issue that is impacting us. It's an external force that we need to understand. Workforce and workforce shortages across the board. I mean, things like phlebotomists have become a workforce shortage for us, MRI techs. And so we have to deal with that just like every other hospital has to. Mental health and substance abuse. And not having enough mental health and substance abuse programs in the community means that people are going to stay in our emergency room or inpatient areas for longer than need be. Long-term care and tough access to long-term care beds is also a challenge. And that might be by supply, but it also may be by payer. There's been a tremendous growth in Medicare Advantage as a plan for Medicare beneficiaries. A lot of them don't pay for post-acute care settings. And so we have patients that will stay in hospital beds for way longer than they need to. They're really getting custodial care at that point in time. We're not getting paid for it because we get paid by a DRG that says you only get so much. So, it's a day and a half basically, and they're in there for 6 weeks. Sorry. But what's worse, it's not good for that patient. They don't need to be here. They need to be somewhere else, but we can't get them somewhere else. And then I think the final external issue is the regulatory environment. Please don't get me wrong. The cost of healthcare in Vermont is too high, but how government goes about trying to regulate that, and that's both the federal and the state governments, is also sometimes a threat and certainly an external force that we need to constantly be evolving and coming up with a better delivery model than we have that can actually succeed in this whole new world of value-based payments. So I think they're the big challenges that we have. But I would say, our friends in Rutland, our friends in St. Albans or Morrisville, all of them are facing those same challenges, just maybe to different varying degrees.
That's just a fascinating insight into the challenges of leading in a rural environment. I want to close on just a couple of quick questions about leadership. We've talked a lot about leadership, kind of. So I want to ask you, just kind of, if could you encapsulate your leadership philosophy in a sentence or two?
Well, I hope that, well, it's so funny. Patrick Lencioni, who I think is a great business writer and management theory writer, has a statement. We need to stop calling it servant leadership. It is the only type of leadership. I still use the term servant leadership, and I hope that is my overarching philosophy of leadership. And I agree with Patrick Lencioni. It is the only kind of leadership. It shouldn't be a component of leadership. But I believe a leadership philosophy that is really emphasizing serving others, trusting and empowering others. I believe that is what I try to live by. I believe that is servant leadership. I also believe that is the right leadership, the best leadership. And so I do try to live by that as best I can.
How does your so this was not a question I had prepared, but since you told me you're a ordained deacon, I've had to ask, how does your Catholic identity influence your leadership
Well,
thinking?
it's a great question. So a deacon, I believe it hits my leadership philosophy head on. So a deacon is actually there to be the servant. What we do at Mass is serve the congregation, but also the priest. The priest has priestly duties to do. The deacon really has service duties to do. And we all have to have a service ministry as deacons because that's what we really are called to do. So I think it shaped my management philosophy a great deal. I think, the challenge in a community hospital is that you can potentially come at odds with your Catholic faith and services that need to be provided in a community hospital. I mean, we follow the law, so we do provide abortion services here. Obviously, that's not necessarily consistent with the teachings of the Catholic Church, but we do them here. We do them safely. Vermont has some odd rules about kind of assisted suicide, Act 39. And we do those here. We don't do them within the walls of the hospital, but our practices can prescribe the medication. And so I constantly have to remind myself that there's laws and then there's my values, and that my job here is to uphold those laws. My job in life is to follow my values. So there are times where they feel as though they're in conflict, but really that's just with me. It's never something I would put out on the organization in any way.
So last question. Since I teach young aspiring healthcare leaders, what advice would you have for a young person looking to come into healthcare at this kind of point?
I would say, take it on with a tremendous amount of vigor and realize that innovation is just wide open here. You talked about some of the external influences. On a positive side, I believe artificial intelligence is going to be a very positive influence for the future. I find healthcare to be unbelievably exhilarating. First of all, it's going to be here forever. It's not an industry that's ever going to go away, but it's always going to be in constant change. And I think the more change in your industry, the more change that you go through, you grow rapidly as a leader in healthcare. I would encourage people never to be afraid to take those chances, to step out in leadership. If you think that there is a perfect pathway to excellence, there is none. You have to figure it out on your own in healthcare, and I find that very exciting. But I also think that can take away any intimidation. There's no right or wrong answer. You just do the best that you can and constantly strive to innovate, constantly strive to make sure that you are growing as a person, as a leader, and helping that organization grow because it needs to constantly grow. This healthcare is a living organism, and you need to be out there cultivating the growth of that living organism. I find that fun, exhilarating. Most of all, I find it fulfilling because ultimately it goes back to the reason why I got into healthcare, and that was to serve the most vulnerable among us and to try and have a profound positive impact on their hope, health, and lives. And every day you can find that you're doing something like that in healthcare leadership.
Chris, thank you so much for your time today. This has been great. Really enjoyed it.
You are wonderful to talk to. It's always a pleasure. Can't wait to see you again too. But it's always a pleasure.
You've been listening to the Health Leader Forge. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again soon.